Welcome back, focused learners. We're diving right into part 60 of our massive CPC exam series today. We're tackling radiology CPT coding case studies pulled straight from the latest study guide. This explainer is going to give you the exact logic you need to completely conquer this section of the exam. Before we jump in, make sure to like, share, and subscribe to Decode Healthcare with Harshal.
Consider this agenda your exam syllabus. We're hitting radiology modifiers, X-rays and mammography, CT and MRI, diagnostic ultrasound, radiation and nuclear medicine, and wrapping up with a visual cheat sheet. Okay, let's dive into this.
Section 1, Radiology, CPT, and Modifiers. Let's lay down the foundational rules first. So, the radiology section covers codes 70,010 through 79,999, and it is heavily descriptor-driven. You're not just, coding a picture. Your code selection depends entirely on the specific modality, the precise anatomy, whether contrast was used, and exactly how many views were taken. A massive chunk of radiology coding boils down to components. Services are split up. Modifier TC, that's your technical side, the facility, the equipment, the techs. Modifier 26 is the professional component, the physician's interpretation and written report. Now, if the exact same entity provides both, it's a global service, no modifier needed. But hey, if your exam scenario specifically says the radiologist interpreted the film only, you absolutely must slap on Modifier 26. Moving right along to Section 2, Case Study 1, Diagnostic X-rays and Mammography Rules. Let's see these rules in action. Okay, watch out for this classic exam trap: views versus projections. Listen carefully. Code selection is strictly determined by the number of views actually documented as performed, not what the doctor ordered. If 3 views were ordered but the chart proves only 2 were actually done, you code for 2 views. Simple as that. For example, a 2-view chest X-ray is going to be exactly 71046. What's really fascinating here is how CPT handles mammograms. Screening mammography codes like 77067 are inherently bilateral. They just are. You don't need a modifier for both sides. But the second it turns into a diagnostic mammogram, boom, you got to watch your laterality. You have to actively choose between the unilateral code 77065 and the bilateral code 77066. Section 3, Case Study 2, CT and MRI coding hierarchy and contrast material. Whenever you spot a CT or MRI question on the CPC exam, your brain needs to instantly jump to contrast rules. There are 3 distinct code categories here. The scan is either without contrast, with contrast, or without contrast followed by with contrast. That third option basically means it's a 2-phase study. You really have to dig into that radiology report to see exactly which phases actually happened. And here is the absolute golden rule, the critical contrast rule. If a patient drinks the contrast or receives it rectally, it does not count as with contrast in the CPT world. No way! Contrast has to be administered intravascularly or intrathecally to get that label. Oral contrast means you code it as without contrast. Do not let the exam trick you on this one. All right, Section 4, Case Study 3, Diagnostic Ultrasound and Vascular Studies. Ultrasounds are all about the extent of the anatomical evaluation. Here's the deal. The difference between a complete and a limited ultrasound has absolutely nothing to do with the length of the report. A complete ultrasound means the doc documented every single anatomical structure specified in the CPT guidelines for that specific code. If literally one single required organ is missing from the documentation, bam, you have no choice but to drop down to the limited ultrasound code. Section 5, Case Study 4, Radiation Oncology and Nuclear Medicine. This part tests your grasp on phase logic. Radiation oncology works in strict sequential phases. You can't just slap one code on the whole shebang. First, you've got clinical treatment planning and simulation, then medical radiation physics and dosimetry, and finally, treatment management. And keep in mind, treatment delivery codes are fraction-based. For example, code 77427 is billed in increments of 5 fractions. When we get into nuclear medicine, those 7800 level codes, remember that the tracer administration is usually bundled right into the primary code itself. Your main job here is to carefully separate the diagnostic scans, your PETs, SPECs, and bone scans, from the therapeutic radiopharmaceutical treatments. Section 6, our outro and cheat sheet. We've blitzed through a ton of ground, but before we wrap this explainer, I've got something to help you lock it all in. Here is your visual cheat sheet. Seriously, go ahead and pause right here, take a screenshot. It sums up all the heavy hitters: modifiers 26 and TC, that sneaky fuse rule, the oral contrast trap, and the strict complete versus limited ultrasound rule. Keep this in your back pocket for your exam prep. And that officially wraps up radiology. But I want you to think about this. How often does one single missed lab test change the entire trajectory of a patient's coded chart? The answer is probably going to surprise you. Join us next time for part 61, where we are going to completely demystify pathology and laboratory case studies, from organ panels to drug testing. Until then, keep studying hard and make sure to like, share, and subscribe to Decode Healthcare with Harshal.